Good morning, ladies and gentlemen. First of all, I would like to thank the organizing committee for this wonderful opportunity to present you this talk. I'm a pediatric gastroenterologist and hepatologist, and the outline of my presentation today will include a very brief reminder of the background and the clinical presentation of the disease, the features of the liver damage. We will also speak about the Quebec patients treated with NTBC, and finally we will discuss about the remaining chronic challenge with the liver. As you know, tyrosinemia type 1 is an autosomal recessive disease of the tyrosine metabolism characterized by the deficiency of the fumaryl acetoacetate hydrolase. To date, there are more than 40 identified mutations, and as shown on this slide, the metabolic pathways in the metabolic pathways, the deficiency of the FAH enzyme will lead to the accumulation of some toxic metabolites. Those metabolites will target some specific organs, mainly the liver, the kidneys, and the neurologic system. In the presentation, we may distinguish an acute versus a more chronic form, depending on the age of the onset, first months of the life versus after the first year, depending on the progression of the disease and the severity of the liver injury. The accumulation of the metabolites like the mallyl acetoacetate and fumaryl acetoacetate may be considered as the biochemical basis for the liver cell death. Those products are some reactive, unstable compounds, and they will interact with glutathione. Glutathione is a peptide implicated in the daily detoxification process in the liver. He is acting as a cofactor, and after the reaction with those metabolites, it will be depleted in the tyrosinemic patients and will induce the problems. Classically, on the clinical front, those patients will have the usual signs of hepatocellular insufficiency. That means clinically some failure to thrive, presence of hepatomegaly, splenomegaly, some jaundice, the bleedings, the susceptibility to the infections, the development of acids. Biologically, they will have increase of the serum aminotransferase level, some cholestasis, coagulopathy, presence of neutropenia or thrombopenia, and some increase of the alpha-fetoprotein level. Those patients are at risk to develop fibrosis and secondary cirrhosis, and another major risk is the development of hepatocellular carcinoma. Other people will talk about more in detail about the treatment, but we know that historically the diet was the unique possibility to try to control the disease. Then the liver transplantation was introduced. In Quebec, the first liver transplantation was performed on July 85 at Sainte-Justine Hospital, and currently it's the unique curative treatment. Of course, at the beginning of the 90s, the development of NTBC and its positive effect as inhibitor of one of the first step of the tyrosine cascade was very, very important. Its first use in human was on February 1991, and 3 years later here in Quebec. Now let's talk about the cohort of the Quebec patients. I will first present you the results concerning patients who never had some liver transplant, because other people will talk about that during the symposium. Currently, we have 88 patients treated with NTBC. In the majority of them, the great majority of them, a neonatal screening was effective. The median age of those patients is approximately 14 years. The first used was on a 5-year and 4-month-old patient on February 1994. When we look to the NTBC start age, it's going from 2 days of life to almost 22 years now, with a mean of 11.5 months and a median of 25 days. After almost 24 years, we have a duration time for NTBC going from 5 weeks to 22 years almost, mean 12 years and median almost 14 years. In more than 75% of patients, NTBC was started during the first month of life. When we look to the serum aminotransferase level, they are normal in 92% of our patients. In 8% of those patients, we have a very moderately increase of the ALT level. The alpha-fetoprotein level is normal in all patients except in 2 very interesting cases. I will discuss more in details in a couple of minutes about those patients. 12 patients had one or more than one biopsy of the liver. Globally, the results were acceptable, which means normal F0, absence of fibrosis, or maximum F1 level of fibrosis, except in 2 specific patients, and I will discuss more in details also about those patients. In our center, the protocol for the medical imaging consists to do twice a year abdominal ultrasounds. And once a year, we are proceeding to the liver MRI. Historically, it was with the classical gadolinium as a product of contrast, but recently we decided to try another product of contrast called Primovist. Primovist is another derivative of the gadolinium, but is more specific for the liver tissue. And you'll see that maybe it can be interesting for the future with the specific cases that I will explain you. Recently, we also thought about the interest of the use of a new technique called transient elastography called FibroScan. Actually, it's not so new, but it's quite new in pediatrics. It's a measurement of the liver stiffness. And we thought about the interest of that because you know that the liver biopsy is something quite invasive and not always reliable because there may have some limitation to do that. We selected 10 patients. All were adolescents or young adults with a medical history of ALT increases. And the results were quite, I would not say disappointing, but they were normal, actually, except in one patient where there was just an F2 level fibrosis. All the others were normal. We decided to do that on those ones also because the standard values of the elastography were developed for adult patients, and for very young patients we have no classical values, so it may be difficult to do it just in very young patients. We'll see in the future how it will be going. We also looked for the liver steatosis. 8 patients, all were adolescents or young adults with increased BMI, and we found some at the liver imagery some signs of the steatosis. Here are the very interesting specific cases that I would like to underline. The first patient is a young adult with a neonatal screening. He started NTBC at 5 months of age. His plasmatic level of succinylacetone is at the upper limit of the normal. His alpha-fetoprotein is increased around 50, but is stable for the last 15 years. The imaging to date is normal, which means ultrasound liver MRI with gadolinium, and also the PET scan. He already had a liver biopsy. It was normal except for some amount of steatosis, and the elastography was also normal for this patient. In the upcoming days, this patient will have a liver MRI with the Primavist. For patient 2, it's a little bit different because this patient, also young adult, also screened during the neonatal period with an NTBC start around 8 months of life, normal succinylacetone, normal alpha-fetoprotein, normal elastography, and normal liver biopsy. But he has currently moderately, very moderately increased ALT level, and his imaging are quite interesting because we frequently found some hyperechogenic liver lesions in different segments. We thought that it was compatible with some steatosis. His liver MRI with gadolinium is normal. The PET scan was normal, but he will also have liver MRI with the Primavist as contrast product. And the third patient is a young adolescent. This patient was not screened during the neonatal period. He presented with some neurologic episodes, some porphyric attacks episodes at 10 months old. And he started the NTBC around 11 months. Normal normal ALT level, normal elastography. In the past, he had 2 liver biopsies, and the results showed a marked fibrosis. And as you can see on at the bottom of the slide, his alpha-fetoprotein level is increasing for the last 5 years. All the imaging techniques were normal until a couple of days or weeks, where the liver MRI with the Primavist showed the presence of 2 nodules, and this patient will be probably evaluated for liver transplantation in the upcoming days and weeks. Those cases illustrate very well the challenge for the liver and for from the hepatologist point of view. When we have nodules, of course, occasionally it can be related to local steatosis, but we need to be very careful and to check for cirrhosis and HCC lesions during the follow-up. When there are signs of cirrhosis, it is an indication of liver transplantation. Currently at Sainte-Justine, in our protocol, with normal imaging, when we have increased alpha-fetoprotein, we are doing a closer follow-up. We are careful, of course. As you saw in the previous slides, we have no tons of examples of that, but definitely it's something where we need to be careful about that. The risk of cancer, and mainly the hepatocellular carcinoma, is always important because historically the incidence was quite high, but in our experience it's about around 17% of the case. It can occur at a very young age, and the problem with HCC is related to the difficulties to interpret the levels of the alpha-fetoprotein, because we know that HCC can occur with normal alpha-fetoprotein level. There is no identified other very highly specific biology for HCC in tyrosinémic patients, and we are wondering if the Primavist as a new, not new, but as a new way to do our liver MRI is interesting or not. We'll see that in the upcoming weeks and months. Just a single slide concerning the liver transplanted patient who received NTBC. Tomorrow, Dr. Alvarez and Dr. Bilodeau will speak in details about the patients who were liver transplanted, but when we look to those patients who received NTBC before the liver transplant, we have 8 patients. 5 of them were older than 2 years old when they were transplanted, and 3 of them were very young. The indication for the liver transplant were the presence of nodules in 6 of them and evidence of HCC in 2 of them. The mortality in this group is lower than in the liver transplanted but previously non-NTBC treated patients. Altogether, the message for this slide is to say that NTBC probably makes the patients more healthy and more in a better optimal situation before the transplantation. What about the long term? We have limited, but we have some interesting data because we have now 24 years after the beginning of this drug. The positive effects definitely concern the survival rate, which is amazingly different. The quality of life also. HCC risk seems low, even if we need to be careful about that. The glomerular filtration rate is normal if there may have some possible tubular dysfunction. We have no cases of neurologic attack of porphyric episodes and very limited number of ocular effects. However, we need to check the risk of HCC at a very long term. We know also that the relationship between, there is no direct or clear relation, signs of relation between the alpha-fetoprotein levels and the use of NTBC. The risk of cirrhosis is always, maybe always present. And as reported in the past, and mainly in a French study on 2008, there may have some side effects or some problems chronically concerning the school difficulties and the cognitive difficulties of those patients. On conclusion, I would say that NTBC represents definitely a tremendous step in the management of tyrosinemia type 1 with a hindsight of 24 years. Its safety seems good, very good. The risk of HCC needs to be closely monitored. And as it will be also discussed by other specialists during the symposium, we have big hopes from the cell therapy. Thank you for your attention.
Est-ce qu'il y a des questions? Any questions? Yeah, there is one. Charles Morin.
Charles Morin, pediatrician. 2 things. One of your slides, what happened to methionine metabolism? Because if we give the NTBC, as I look on your slide, with the FAA, then there's the methionine. I remember many years ago with Dr. Lawachelle, he was telling me that methionine could have a role in terms of toxicity and everything. So do you know if it plays a role? And does the NTBC has an impact on the methionine metabolism? First question. My second question is, how do you monitor patients on NTBC? Because they are adolescents. And then we say, oh, okay, he has the patient you mentioned was not screened, but there have been many patients who were treated later on. Once they're on NTBC, do you dose it? Do you have pharmacologic levels to follow? Or my main question would be, how do you check compliance to NTBC? Thank you.
Welcome. Yes, for the follow-up, the appointments for patients are multidisciplinary, and I'm very often, I would say even always present with Dr. Mitchell, and they are proceeding to the dosage of the nitisinone of the NTBC in order to target a good level of that. At those appointments, they have also, of course, classical biological tests with the dosage of the ALT, but also blood formula and all the other classical biology tests. They are also doing the ultrasounds and the liver MRI once a year. So biologically, yes, we are able to see if they are taking or not, if there is a problem in terms of maintenance of the status of NTBC. He would be, he can explain you in more details. Concerning the methionine, of course that it's difficult currently for patients who are not liver transplanted to. It's not easy for patients who are not liver transplanted to know this level, but for patients who were liver transplanted, I think that there is definitely some chronic evidence that the metabolism of the methionine was definitely increased, and they will be in better situation to explain you that during their presentation.
Question over there? Yeah.
So, what are your thoughts about where the succinyl acetone could be coming from in patients that are on NTBC?
Excuse me, can you repeat?
So your three special patients that you presented, they have elevated succinyl acetone, even though they are on NTBC. Mm-hmm. So how can that be?
Honestly, I think that it's three different cases. The first one, the first patient with 50 is at 50 for the last, I think, 15 years. When I started to follow him 5 years ago, I was, of course...
Not the alpha-fetoprotein, the succinyl acetone.
The succinyl acetone level. The last...
Where is that coming from?
The fact that it's increased?
Yes.
Probably that... I don't know if the timing of the timing of this NTBC start may be may have an influence about that, but it seems that when we look, I've not shown that. I will just show you another.
Maybe Grant has a comment on this.
Yeah. That's more my department, because we're very multidisciplinary in the clinics. The succinyl acetone is not elevated. There is a normal level of succinyl acetone detectable in everyone. It has been described by Cornelius Jacobs, and the lab in Sherbrooke that does the testing for us. It has shown that the upper limit of normal for succinyl acetone is about 24. So most of our patients do have normal succinyl acetone levels. Some have slightly elevated with respect to the normal values. So these patients have normal succinyl acetone. Oh, I see.
And I don't know if it is very relevant. I choose to not show you the slide due to maybe some time limitation, but when we compared the succinyl acetone levels between patients who received NTBC during the first month of life compared to the others, the first group, those who received that during the first 4 weeks of the life, were definitely lower than the others. In the other group, there were a couple of patients with very, very limited, moderately elevated succinyl acetone level, and the difference was significant. So I don't know if it is really relevant, but when we compare that, there was definitely a difference between those two groups.
Excellent. Thank you, Dr. Halac. Thank you.